having to convince this individual of the same thing, all right? They just don't know how bad it is. They're hoping it's not, they're fearing it might be, but you're having to make sure they understand. So one of the first things I will start with is range of motion, active range of motion. So I have them scoot back so that their heels are on the table. And let's say her right leg is the injured leg. So I will say, okay, bend the uninjured. Okay, as close to your, put it as close to your butt as you can get it, but don't touch it with your hands. And I'll mark where that spot is. Okay, you just moved it. Okay, now straighten your leg, and then I'll have them bend the other leg and see how close they can get. Let's say you're injured. Okay, let's say she's pretty injured. And so then I'll mark that one, and then I'll say, okay, now straighten your leg. And I'm looking at two things. What's the first thing I'm looking at? The difference between the two. And I make sure that they see where my fingers are, so that they see it's this much. You know, you can't bend that injured leg very far. What else am I looking at when they bend and extend?
And then see when it's painful.
I probably know it's painful.
If anything moves.
Huh? No, not yet. Not yet. If anything, what moves?
Like on the knee or something, like it doesn't move as supposed to move.
No. I thought you were going in the right direction, but never mind.
Just look and compare. Like for example, one is showing the other one, the muscle here.
Okay, I might be looking at muscle quality, but I'm looking at the quality of movement. All right, so the uninjured side is going to be real smooth and fast and nice and easy, you know, just thump, 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 back and forth. The injured side, depending upon how severe it is, they may move it very slowly and very cautiously, and I bring this to their attention. All right, so I want to make sure they understand that these are issues and these are problems. When I evaluate the patella, to evaluate for patellar apprehension, I don't know if you guys can see this. You guys need to move this side, because I'll stand over here and do the test so that you guys can all see. If you're like right here, you're okay. For patellar apprehension, if I think there's a chance that she might have dislocated, all I have to do is move the kneecap to the side. And if it feels like it's going to go, they'll go, there's apprehension. Not only will she be apprehensive, the area that has gotten torn, if she dislocated, is going to be very, very painful. And she won't like that, all right?
No, my kneecap's so hard. That's her injured leg.
Besides, hers looks like that. What's the next thing I'm supposed to look at? Here, sorry. Got my I also, okay, so if there isn't any indication that they have dislocated, and I'm not concerned about apprehension, then when I move the kneecap, I'm going to push it to the side as far as I can get, and then see how far underneath the bottom, the border that I can get, and then I'll move it to the other side and palpate underneath as much as I can, and then I'll palpate the superior, and I'll push on the top and palpate the inferior, and see if there's any pain or tenderness. All right? What am I looking for when I palpate and try and get underneath the kneecap? What's it called? Anybody know?
Come on, I'm trying.
If I palpate underneath,
Aren't you getting in that cartilage?
getting on the cartilage underneath, and if they say, oh yeah, that hurts, it's known as chondromalacia.
That's what I was gonna say.
Which is not something I told you had to have. That was right on the tip of your tongue, wasn't it?
Yep.
You don't need to absolutely know this for this test, but just to let you know, that's one of the things we look for. And if they have that, chances are the next test is evaluating the condyles. I will bend the knee and I will palpate the condyles. Here's the tibia, here's the femur on the lateral side, and the tibia and the femur on the medial side. If they're dragging and the kneecap is moving at an angle, which is known as, what's it called? Patellar,
Femur.
femoral,
Femoral.
stress
Stress.
syndrome, PSSS, which I think is on this paper. Then that chances are, if they've got pain on those condyles, more than likely you've got a tracking issue. And if you have a tracking issue, all you have to do is come down here and say, okay, tighten up those quads. And then when they, not just this side, and relax. And when they relax, you can see the kneecap. Now she has a tracking issue. So all you guys have to do is watch this kneecap when she relaxes. So tighten up and relax. See where her kneecap goes?
Like that.
So she's dragging this direction. All right? So in the book it said, oh, well, you measure this from here to here, and then you measure this from here to here, and then you go to the angle. I have to do this more. And if they're painful, underneath and on the condyles, tibial and femoral condyles, something's up, because they shouldn't be painful there. Now, are there other things that could happen here? Sure. Could there be chip fractures of some sort? Yeah. But the mechanism of injury should tell you that. And if they had no, fall down, go boom, bumped into the wall, ran into the fire hydrant routine, then chances are it's a tracking, especially if they track poorly. Patellar tendon, all you have to do, the easiest way to get to the patellar tendon, and chances are their pain is going to be on the infrapatellar. Every once in a while we get somebody that's got pain on the superior, but most of the time it's here, probably 95, 96, 7% of the time. And all I do is I get down here on the tibial tuberosity, okay, this little bump, and I simply go to the medial, lateral side, and go up to the patella and ask, is this painful? And I get up to the kneecap, go up the middle, and see if it's painful. And then I will back off just a little ways from the bony structure, and I will just push just a little bit. And I'll see if I can find crepitus. Not find anything. Did we ever have crepitus on you? That will
Yeah.
Okay, but that's gone now, huh? Oh, good. Well, that's good. Anybody else have
That's a
tendinitis?
little compliment to me.
Anybody have tendinitis? Knee, patellar tendonitis? All right.
I have the elbow.
Yeah.
Stuff
If
like
I
that.
ever have, find anybody that
Telling
has
me
something, we all
something.
get to, play with it and find out what it is. But it literally, you put your finger on it and push just ever so slightly, and you truly get this little squeaky feeling. And that's exactly that's the best way I can describe it. It feels squeaky. And that would be some crepitus. Hamstring tendons. Bicep femoris attaches to what? At the knee. At the knee, it attaches to what? Okay, the head of the fibula. So all you have to do is find the head of the fibula, okay, and then you just walk back. Okay, so I find the head of the fibula, and I walk back, and lo and behold, look at that, there's a tendon. Now, if we're having a hard time finding the tendon, and with some athletes and some people, depending upon what their body type is like, it is hard to find them. So the easiest thing to do, we'll do this one at a time. We'll do it for you guys on this side. Dig your heel into the ground. Dig, pull. Can you see this right here? And all you do is, as soon as she digs in and contracts that muscle, you can walk all the way down to the head of the fibula, and boom, it just jumps right out at you. Almost lands in your lap. All right, on this side, dig in, and there's that tendon. Okay? By semi-membranosus, keep this leg down. For you guys over here, dig in. Can you see this tendon right here? Okay, so there's one that disappears into the back of the joint, and there's one that comes around the corner. The one that comes around the corner is the longer of the two, semi-tendinosus, longer tendon. All right, the semi-membranosus attaches or inserts into the tibia, the tibial condyle of the back of the knee. All right, so you guys on this side, dig in.